So as you see, my name is Dr. Mikaszewska. I'm coming to you from Warsaw, Poland. So English is not my mother tongue. You must forgive me if I do some mistakes or so on, but I hope you will understand me. I am talking to you about the tiniest lung, which are the baby's lungs, who we are dealing with in the anesthetic room. And no doubt, ventilation is a life-saving procedure, yes, and it is something which is a huge development to save human lives, but it can be dangerous as well. And regardless how big is your experience and how good equipment you have or how long you work, the anesthesia for children, very small children, premature, is always a challenge for the anesthesiologist, because most of the complications in anesthesia in small babies are coming from ventilatory and airway management. And this is the main goal, to protect it. On the other hand, things like, the dead space or the additional space added by the monitoring apparatus, yes, or the air leak, which are of small importance in adults, are of great importance in children, because it takes the factic volume of ventilation. So this is really important to protect children. And Luciano Gattignoni, he coined the term baby lung. This was to explain the adult anesthetist to understand how the diseased lungs of adults work. Once they have RDS, once they cannot expand the lines, once the gas exchange is not possible. And this lung was the healthy baby lung. And we will be talking about lungs which are diseased, so it is even more complex situation. The changes are various in the lungs during the ventilation, because some of the damage and some of the response for the insult is automatically released. This is the picture of little Mia. This Mia is in my intensive care unit at the moment. She was waiting 6 months for surgery because she has asphyxiating thoracic dysplasia, or Gene syndrome. Very severe situation, because those children don't survive to adulthood. They usually die from respiratory complications, and the the death rate in this group of patients is up to 70%. If they manage to survive somehow to these school years, they have problems with kidneys. So it is a very serious complication. And for the kind of treatment for these children is either to do the surgery through the sternum and put some graft, debonic graft in the sternum, either to put extendable rib and extend it every 3 months, to make the chest bigger, or to put the plates both sides. But to have child like this, with the lungs looking like this, you have to have a plan how to go safely through surgery, because the surgery is done on both sides, thoracoscopically. So every lung is compromised during surgery, which is not easy. The fatality rate among ventilated children remains high. And the factors which are responsible for this fatality are very poorly defined. If you look on papers which publish the results in ventilated children, the groups are very small. Many of them concentrate on surgery, on surgical techniques, on fluids, on anesthetic medication used, but almost none of them, or very few of them, concentrate on ventilation itself, which is of the pyramidal importance. There are some lung protective protocols, but you know that they have been implemented in adults. They have been implemented by the Arts Network, and Gordon Rubenfeld, who was one of the signatories of those protocols and who did the survey 1 year after implementing this protective protocol, he discovered that more than half of the group which was investigating and then implementing the protocol, doesn't use the protocol any longer in practice. So that's another thing. People know that they can protect lungs, but they don't do it. And the other very important thing is the extubation failure. We don't really have the good tests to like spontaneous breathing trial and so on for small children. Yes, it was never validated. And you very well know that reintubation and ventilation afterwards is prognostically even worse than the damage done during surgery itself. This potential risk of mechanical ventilation was spotted already in the 70s when we started widely ventilate those children. But as you see here, the routine mechanical ventilation of healthy patients can increase the production of pro-inflammatory cytokines and the incidence of villi, and this incidence in healthy people is estimated between 22 and 39%. This is the message from adults, yes, with quite different lungs, which more plastic lungs, which are more elastic lungs. And this increases up to 83% in the pre-existing lung disease, which is really horrifying message. There is a myriad of factors during ventilation which can stress the lung, give the strain, and give some damage to the lungs. And this biotrauma, which seems to be the most pronounced one, is the consequence of it. Yes, because for this tiny damage, the cytokines are released, the complement is activating, the reactive oxygen species are released. So we are coming back to our babies, and this is not only the smaller chest, but quite different shape of the chest, quite different location of the diaphragm, quite different motility of the diaphragm, because it cannot expand as deep as it expands in adults. The chest is highly compliant, so it means that it won't compress, it will won't protect the lungs from collapsing. The diaphragm is morphologically flattened. The ribs are horizontal, so we are doing our ribs to the horizontal position when you want to inspirate. They already have an inspiratory position. There is also few fatigue-resistant fibers, so they get fatigue very easily. And during REM sleep, the intercostal muscles activity is inhibited, so only diaphragm is left for the ventilation. We all know, because we deal with it in the theater, that the anatomy of the head is different. Yes, the airways are very wide on this first part. Yes, just to do the good passage of the air through the airway, but then. We very frequently deal with the difficult intubation in those children, and this difficult intubation also means the damage to the airway, and also means that there might be the bronchospasm afterwards. This is why we need our small left finger just to help ourselves with the larynx. This hyperactivity of the bronchial tree, I think every one of you who is working in ENT surgery, obviously those children are bigger, but we do this just simple procedure for the synthesis of the ear to release the fluid from the internal ear, and out of the blue they get the bronchospasm, and you have a very tiny volume which you have to squeeze to the lungs very softly just to ventilate the patient. So it is very important to have the machine or to be able to do it very plastically, because this bronchospasm doesn't leave off very quickly. It takes, so for the procedure, which normally lasts 15 minutes, it has like 20 minutes, half an hour, or even 3/4 of an hour. There is a high airway resistance, and it is like 5 times or 7 times more than we have, because the adult has between 10 and 15. The children has resistance up to 75, and it stays high till they are in the primary school. So it's a long time when they have this resistance. Once there is a swelling of the airway, the turbulent flow increases, so the efficacy of the gas exchange is also impaired. And this swelling and this increase in resistance during this bronchospasm happens in these first 3 generations. So there is not much left for the generations afterwards in the lungs. the FRC is small. It is very close to the closing capacity. So every ventilated child has atelectasis. They are easy to barotrauma because the pulmonary compliance is much less than chest compliance. They are more sensitive to volutrauma. You know, this volutrauma when we overexpand the lungs, but also to the volutrauma in this beginning of the curve when we inflate the lungs, because there is also a damage which comes to the lungs. And of course, because they breathe more frequently, because the breath rate in the neonate or premature neonate is like 60, so it means that the oxygen consumption is higher and the reserve of the oxygen is smaller. So for apnea, usually we have the reserve of 3 seconds. 3 minutes, yes. In children, we have half a minute, yes. So it's a very, very little time. Another thing is, and we know it very well, that there is a physics and mechanics, and we all know that the spontaneous ventilation and the mechanical ventilation differ because the pressures are different. But to this picture, we had to add the situation that I'm not very good, so maybe I will just show it with this one. The surgeon comes either here or there, so still you have additional intervention and additional increase in pressure because of the surgical intervention done to the chest, and you have to deal with it because you still has to keep the airway open and you still has to keep the gas exchange in the chest. This is the most important. Graph because we need to stay in this normal FIC just to have the child ventilated properly. If we do the overexpansion, we have overdistension and we have lung damage. But as I said you before, the same lung damage happens if you have this lower FRC and the atelectasis are coming. The air and water are smart, so they flow always to the space where it is easier. So if you have atelectatic part, it is just devoided from flow, regardless what is it, the fluid or water. So it means that you have to open the lung first, just to have this area attracted to the gas exchange. You open it incrementally with gas, with this lung recruitment maneuver. But once you open it, you need to protect it from collapsing, yes? And then you need a PEEP which will keep the airway open. And then you have to choose the lowest possible PEEP to have them open for the future gas exchange. So what is the most important in this lung recruitment or lung protective maneuvers is to keep the lung open for in the first instance, and keep the lung at rest as long as you can, because it will give the most effective gas exchange in those children. This paper identified the most popular risk for pulmonary complications, and the incidence, as you see, is up to 70%, which is not nothing. The pulmonary complications after surgery are the quality indicator, which means, and this is the quality indicator which we have huge part, we influences in a huge part. These 5 independent factors are small corrected gestational age. Use of preoperative pulmonary ventilation because the lung was diseased already before the surgery. And if you don't have plan during your surgery for this diseased lungs, you are damaging it. It's obvious. Yes? So you must know what is the pathophysiology and what can you do not to damage the lung. The length of operation up to more than 60 minutes, and intraoperative albumin infusion. And after yesterday's lecture, one of person from the audience come to me and say, so shouldn't we give albumin? Of course not. But you must be aware that the more you give, it will have the consequence, because there are surgeries like, liver surgery, and so you cannot avoid albumin. They must be given, yes? But you must keep in mind that this albumin is first making this water dragging to the vessels, but then it comes out to the interstitial space and it is dragging water out, so it will just make your lungs more watery. This is the work done by the group which was trying to intubate, identify the pulmonary complication after surgical procedures. They were doing this survey in a group which was not more than 1 week old, so it was 4 hours up to 1 week. And they have identified longer opioid infusion and lower gestational age as the risk factor for prolonged mechanical ventilation, which is in fact the pulmonary complication afterwards. And as you see the previous one, and as you see this one, none of them was alluding to any setting of ventilator. There was nothing was said about the PEEP, nothing was said about the driving pressure, nothing was said about the volume of ventilation. It was more or less only about the technique and the age of the child. So we already know that we shouldn't exceed the tidal volume of 6. So something between 4 and 8 is optimal, but we keep it about 6. We already know that we should have PEEP at least 4 for these lungs, and of course we should implement the recruitment maneuver if the gas exchange is failing or is deteriorating during the procedure. The other important thing is that we also need to accept somehow of hypercapnia. And of course, you know that with this quick ventilatory rate, usually we have the inspiratory-expiratory ratio 1:1. But sometimes we need to prolong this expiratory ratio, even in the small children, not to produce the hypercapnic acidosis. There are 4 possible grades of complications which have been identified in a surgical patients. The first grade, as you see, it may be just the high temperature without any other explanation, with some kind of dry cough and some kind of microatelectasis, which you might not even see on the chest X-ray. The second grade is the cough is already productive. There might be bronchospasm, there might be atelectasis, there might be hypoxemia with this alveolar arterial difference of more than 29. There might be some adverse drug reactions in the lungs. These lungs will react this way. Grade 3 is the pleural effusion. That may be pneumothorax, it may be pneumonia, so it's much more severe. And grade 4 is respiratory failure and the need for ventilation for longer than 48 hours. Now we are coming to this practical part of the lecture, yes? It is the thoracoscopy. And in the thoracoscopy, there is a surgeon which comes with pneumothorax, with this artificial pneumothorax, and this artificial pneumothorax is contracting your pressures in the airways. So these authors, they were analyzing the situation when single lung is ventilated or there is a dual lung ventilation. The pneumothorax, as you see, was between 4 and 6. We usually try to keep it around 4. But in the very beginning, even if you have the slow gas flow, like 1 to 2 liters per minute, because you want the small lungs to adapt to increasing carbon dioxide, because there is mainly the carbon dioxide insufflated. There is the volume of ventilation was 5 milliliters for inspiratory volume, and the PEEP of 7. The surgical time in both groups was identical. The anesthetic preparation time was obviously longer, yes, because you need to do this single lung intubation, which is not easy. It is especially not easy in the small children because they are small. You don't have double Ebgen tube for this group of patients. Yes, you need to use normal tube. You need to have a bronchoscope. You need to go directly to the bronchus which you want to intubate to leave the other one open to let it collapse. The desaturation time was 5 minutes, but it was in every third of patient. So it was not nothing. The other work is about laparoscopy. Again, there are the pressures in the abdomen which are counteracting the pressures of our ventilation. And we already know that intra-abdominal pressure can be equally deleterious for the gas exchange as the intrathoracic pressures. And both techniques, thoracoscopy and laparotomy, when they are creating the pressure, they are also compromising the circulation. Yes, so we must keep it all into account. As I told you before, we need to have a plan for this small creature, yes, because the safety of the child is in our hands. So you see in this group, they have a lung protective ventilation, which was, according to PEEP and according to volume, there were the protective values like, 6 mils and 4 centimeters of PEEP, and the recruitment maneuvers. And the second group was just ventilated with the ventilator volume between 8 and 10, without PEEP, because PEEP was 0 and no recruitment maneuvers. And as you see, there were the grade of complications was a little bit different in both groups, and a little bit there was a difference in these in the picture of the ultrasound. So again, it is a very useful tool to use. It is non-invasive, if only there is enough space, because the problem is that those children are very small. The wound is very small. Their fingers are big because they have to deal with the operation. And we are coming with our ultrasound just to make also the examination to see the lungs, which is not easier. Bronchopulmonary dysplasia, those patients are coming to our theater, and they have already damaged lungs because they have prolonged exposure to the carbon dioxide and the pressures. You need to treat it as the chronically damaged lung, with the relatively slow rate of inflation and deflation, because you need to eliminate carbon dioxide. So again, you are extending this time constant for expiration to get rid of the carbon dioxide. Another thing is that in this damaged lung, there is no use of doing the recruitment maneuvers, yes, or to expand the lung, because it may not improve the gas exchange because they are not distendable any longer. The volume of ventilation should be a little bit higher. So if you choose, it would be better to choose 8 than 6, for instance, per kilogram. You will see it, because on the other hand, you must see how the circulation behaves, yes, because it might create the circulatory collapse. And inspiratory time possibly long, because it is just it guarantees your oxygenation in the baby. Congenital diaphragm hernia, it is the situation very seldom now seen in the neonates, because most of these hernias are done as fetoscopic surgery. So whoever doesn't have a inborn cardiac defect is done during pregnancy. But once they come, you have a child on the table with damaged lung, with a cardiac defect, and you need to deal with it during the surgery. So it must be very gentle approach in this patient. You must be very permissive for the lower oxygen and the higher carbon dioxide. And you must also remember that these recruitment maneuvers will not work, because the lungs are not distendable, because most of the bowel contact was lying in the chest and was compressing these lungs for a very long time. Meconium aspiration is very seldom the reason for surgery. Meconium itself is very damaging and very toxic, and also inhibits the work of surfactant in the lungs. But those children sometimes have meconium peritonitis, and this might be the reason for surgery. So again, you have an emergent surgery with a very damaged lung, and you must again keep into account that the area for gas exchange is rather small. Yes, there is some barrier for the outflow of the gas. Yes, because the meconium is moving down the bronchial tree, so it impedes the gas flow during expiration. Ventilatory low should be slower than normally. In the good paralyzed children, slow ventilatory life, relatively long inspiratory time. And necrotizing enterocolitis, those children are very severe. Not every one of them requires mechanical ventilation, but if they do, they go to the theater usually after the drainage performed in NICU. So in this, usually the surgeons just relieve the pressure in the abdomen, and then they proceed for resection to the theater. There is not only the bowels are compromised, because this interplay between bowel and lung is quite big. So the gas exchange is poor in those children, but there is also the poor circulation in the solid organs in the abdomen, which you have to protect. You should use possibly low P inspiratory pressure, and possibly low and expiratory pressure, but again to watch the gas exchange. Thank you very much.